Welcome to Adapting Class, and thank you for deciding to join us. This is second portion of the respiratory prioritization questions. How respiratory pathology can be very difficult, why they can trap you. So let's get to some few questions. I'll show you some of the content areas that you got to be careful so that they don't trap you. These questions will be prioritization. Most of them, every respiratory question, is airway, so you got to intervene, right? But not every respiratory question, when they put it together in a prioritization form, you should pick it as an answer. Typical example is this one, right? I give you six of them, and I will show you how they can try to trap you. And this is a way of several clients on the respiratory unit, right? Which clients require immediate attention? Select or apply. You don't have to pick everything. If you know the answer and you're 100% confident, you pick that one. But the best way to approach it is to don't worry about the diagnosis. So they're going to give you the first portion is going to be a diagnosis. Look at it, all of them. There's a diagnosis, asthma, there's a tracheostomy, there's a lung cancer, right? Don't focus on them. Focus on the other part of the question. That's the modifier, right? A client with obstructive sleep apnea who received IV morphine. Is this worrisome to you? If it is, pick it. If it's not, let it go. But you have to bring your content. What is it about OSA that they have to put IV morphine to them? Why would this be so important? Why do I want you to know? You have to be careful. They can trap you with this information. A client with emphysema who is using pursed lip breathing when walking. What do you think? Put everything together. Your content, bring it together. A client with asthma reporting shortness of breath afterward using albuterol. Should a patient who had a asthma giving albuterol, should they still have shortness of breath after you give them albuterol? A client with tracheostomy with dislodged inner cannula and oxygen saturation of 85. He has a tracheostomy, he came out, and his sat is 85. A client with lung cancer post lobectomy 2 days ago. So remove portion of the lung. We remove one lung, right? And one lobe, basically, not the lung, one lobe of the lung, who is coughing a small amount of blood, thin sputum. Is this what you should expect post-operatively in a patient who just had a lobectomy? So let's look at it. If you know, you can put your answer, but these are five questions. Which of this do you worry about? There's something about OSA that they go into apneic episode, respiratory depression. They stop breathing. If you give them what? Opiate, you have to be careful. They're going to have more apneic episodes. So these are critical patients you have to see. A client with emphysema is using pursed-lipping for when walking. This is compensatory mechanism for emphysema. These allow them to prevent air trapping. You see, so I use content for content and questions to show content. So this is it. The reason why you're doing pursed-lipping is to prevent air trapping. It's not a problem. A client with asthma reporting shortness of breath after using albuterol. If I use albuterol, I should not have shortness of breath. I should get better. If I use albuterol, I may still wheeze. That's okay. But if I have shortness of breath, I'm not responding to the treatment. I should worry about this guy. I have tracheostomy. Came out. My sat is 85. That means I'm desaturating. The next should see something. You should see this patient. I have lung cancer and they remove a portion of my lobe. And then when I cough, there's blood in it. It's expected, right? Small amount of blood thin sputum when you have lung surgery is okay. So watch for these kind of traps and you won't be trapped because you don't want NCLEX to trap you. If they trap you, then you are in trouble. So which are your answer? A, C, and D. But B and E are all expected finding. Same thing, med unit. This is only for a patient. That means you got to pick one. Which one require intervention? A nurse on medical surgical unit is assessing several clients with the respiratory related conditions during morning rounds. So who would she see? A client with the left femur fracture, okay, long bone fracture, who has developed petechia on the chest. Is this worrisome to you? You gotta be sharp. Check be sharp if you want prioritization. A client with left-sided pneumothorax shows a tidling in the water seal chamber of the chest tube. Is this something you should be worried about? A client with pneumonia who is receiving IV levofloxacin. Put your answer down and let's talk about it. A client with left-sided pleural effusion and a decreased breath sound. All of them, bad problem, bad problem, bad problem. But what do you think? Which one do you think it should be the person? If you have 1 second, you're going to give it to left pleural effusion and a decreased breath sound. I have pneumonia and I'm receiving IV levofloxacin. I have left-sided chest tube and there's tidally in my water seal, and I have a left femur fracture and I have petechia on my chest. Who need your 1 second? Think about it and be sharp. The B sharp said breathing shock, bleeding, electrolyte shock, sepsis, airway, and pain. Who is in trouble? Pro-effusion, what it means, if this is your lung, okay, there is fluid here. If I listen to you, you're going to have decreased breath sound. Ignore it. Don't pick it because you see breath sound. If you have pneumonia and you're being treated with antibiotic, there's nothing I can do. If you have left-sided chest tube for pneumothorax and there is tidling in the water seal, it means the chest tube is working. Therefore, left femur fracture with petechia, this is fat embolism. Pay attention to that diagnosis. This is dangerous. Pick that one. Fat embolism. The client with COPD is receiving oxygen via nasal cannula at 4 liters per minute. So you have a COPD patient is getting 4 liters per minute oxygen every time. What would you do? Bring your content related to COPD. COPD need precise oxygen concentration. They should not get anything above 2 liters. If you flow, I give them high flow oxygen, you're going to have oxygen-induced hypoventilation. Once again, oxygen-induced hypoventilation. That means when you give them too much oxygen, they will stop breathing. That's why you give them precise amount of oxygen. Therefore, 4 liters per minute is too much. We need to decrease it to here. We should not switch it to non-rebreather. Non-rebreather will give them more oxygen than a nasal cannula. Notify the healthcare provider to increase it is not appropriate. You should continue monitoring the client. That means you don't do anything. They give you a question, but you want to continue monitoring. That's bad. So watch for that. They need precise amount of oxygen. They don't need a rebreather. They will need probably Venturi Max. That's the best oxygen delivery device for them. Okay. The next is assessing. These are PEDS. PEDS respiratory. Be careful. Those questions can be tricky. They look sick, but not all of them are priorities. Some of them are expected, and you got to be sharp when you see them. So we have 3 kids, 4 kids in the respiratory pathology. They have respiratory symptoms. Who do you want to see first? We have a 3-year-old who suddenly started coughing when he was having lunch, and now he has no breath sounds on the right side and he's drooling. So all of a sudden he's having lunch, no breathing, and he's coughing and he's then drooling. There's a buzzword there. Lunch is your key. Focus on that. 6-year-old with asthma who is upright. He has a respiratory rate of 32 and he's using accessory muscles. Should that concern you? 10-month-old with bronchiolitis. He's having like excessive nasal congestion. He's wheezing. His saturation is 93. A 7-year-old with seasonal allergy with a clear nasal discharge and occasional wheezing. Who is dangerous? If you know, put down your answer. And you can see 7 is not that sick, right? 7-year-old, seasonal allergy, clear nasal discharge, and occasional wheezing. There's nothing buzzing in your ear. C is like RSV infection, 10 months old. The age give it away. They even told you bronchiolitis, right? With nasal discharge, that's what you expect. They're going to wheeze. The saturation is not that bad. It's eliminated. Asthma patient in the upright position, those are compensation, right? His respiratory rate is 32 and he's using his accessory muscle, he's compensating for the respiratory distress. He's the second highest, it's not the first. A 3-year-old with a sudden onset of cough during lunch, that should something should buzz in your ear. That does is what? Aspiration. He may be choking, is aspirating something in his airway. Now he has no breath sound and he is drooling. He can't control his secretion. So this guy is aspirating. Food is choking him. Therefore, he's the one you're going to see. This is the way you analyze questions, and then you will be able to handle any NCLEX question. Same thing, same strategies, same thinking, right? Child, 4 of them, respiratory problem. 2-year-old, what does he have? Croup. What are they telling you? Inspiratory stridor at rest. And then what? Agitation. Should this concern you? 10-month old RSV, his respiratory rate is 58. That's really high, right? He has nasal flaring and he's wheezing. 4-month old Pertussis, he has paroxysmal, what, coughing followed by vomiting. Should that worry you? And a 3-year-old with the runny nose, low-grade fever, and occasional wheezing. That's common cold, expected finding. C, pertussis. They have post pertussis what? Emesis, right? So when you cough, then you're going to have what? Vomit. That is an expected finding. RSV is going to wheeze, you're going to have nasal flaring, but nasal flaring is bad, right? But when you look at one is in trouble. Stridor is common in croup, but being striding while you are just sitting down at rest and you are agitated, that's a sign of airway distress. Agitation is always the beginning of airway distress. So this guy is in trouble. Who should the nurse assess first? But what is the problem? All of them as emphysema. What conditions or findings in emphysema, when you see it, you should know it's a trouble. So look at the 4 of them, all have emphysema. Client with the what? Oxygen saturation is 89. Is using persleeping. Is in a tripod position. Should this emphysema patient worry you? Is an emphysema. His SAT is 89. Is using persleeping to breathe and is in tripod position. 2. His emphysema, he has barrow chest and he has diminished breath sound bilaterally on both sides of the lung, right? C, a client with increased sputum production and the yellow flank. So you have emphysema patient showing these signs. And the last one, emphysema patient with a new onset confusion and a respiratory rate of 8. This is not designed to trap you, to show you that these are COPD patients. They may have certain things you should have to have it at the back of your hand that these are normal, right? Oxygen saturation of 89 for COPD. Okay, that's good. He's using paired sleeping. He's not in distress and he's in a tripod position. All these are compensation. They do it. It's not like they're having problem. It's not a precautions. This is suspected finding to see a COPD patient in the tripod position. So don't take it as like is in trouble. COPD patient using per sleeping, especially emphysema patient, expected. A client with barrel chest and diminished breath sound, COPD, emphysema patient, in order to compensate for the lung and then air trapping, they're going to have barrel chest, they're going to have decreased breath sound. If they have signs of infection, they will have sputum production and a phlegm. Therefore, by default, acute onset confusion is CO2 retention, too much hypercapnia. That is why it's having confusion and his respiratory rate of 8. He's not breathing anymore. This is your boy. Okay. Use the content to analyze the question. You'll be able to figure it out. Don't memorize the question. It's there. The answer is staring at you. It's a pick me. But you got to go through the process, the mental gymnastic, to be able to figure out what is going on. And this is caring for a client with what? Thoracentesis. The buzzword is what? Thoracentesis. What? 30 minutes ago. Bring your content. What kind of content do you know about thoracentesis? What do you expect after thoracentesis? Use it to answer the question and see if you see something it should worry you. Your content is what? After thoracentesis, the major complication is pneumothorax. Look if you see pneumothorax there. A client report chest pain with deep breathing. Of course, your thoracentesis, I stick you're going to have it. Now, respiratory rate of 22. It's not that bad. It's too high, but because you just had procedure, client is leaning forward and appear anxious. Yeah, something is not going well. The next note, absent breath sound on the affected side. If there's no breath sound at all, and I'm leaning forward, I'm appear anxious, I'm trying to compensate for respiratory distress. But if there's no breath sound at all at the site where I did the thoracentesis, of course, pneumothorax. Therefore, this is in trouble. So you have to do the mental gymnastic to be able to figure out what is going on. So that one is your problem. And let's walk into a room and find a client with tracheostomy who is coughing vigorously and dislodge the tracheostomy. So you have a patient who have tracheostomy, is coughing, and everything is out. And the tube came out. What would you do? Put down your answer. Let me see. Are you going to call the rapid response? Think about it. Are you going to insert the tracheostomy tube back? Are you going to put oxygen via the face mask over the stomach? Right? Listen to the breath sound. So listen to the breath sound. Provide oxygen via face mask over the stomach. That means put it near the neck where the tracheostomy is, and then or insert the trach back or call rapid response. What do you think you should do in this situation? Patient has a trach, he cough, and it comes out. Rapid response, yeah, they will come and help you. But patient is is going to be in distress. You should provide oxygen support before the end of the day, before you call rapid response. You can insert the tube back, put in air through the stomach is irrelevant. Either you put the tube back or you cover it. That's the most common scenario. Listen for breath sound. You know the tube came out. Patient need oxygen. Listen for them. It's not going to help you. So not this is the trap. Assessment, assessment, assessment. It's not always right. In this situation, fix the problem. Give the patient oxygen. So insert it back. It's different from this. This is why you don't memorize questions. You learn the content to apply it to the question. This is the same thing. If you say, "Oh, I saw this question was answered," we just insert the tube back, but then this is the question. I change it a little bit, and Chris would do that to you. A client with tracheostomy that was placed what 3 days ago. That is the problem. 3 days ago, suddenly coughed it forcefully and it came up, and the client is in distress. The key is if the tube is placed and it came out within 7 days, never put it back. That is the content. That is the concept. If it's placed within 7 days and it came out, don't put it back. Cover the neck with the gauze and give them oxygen through the nose. Rapid response, yeah, they will come and help you. But the patient, you can do something without calling rapid response. You do that before you call them. Insert the tracheostomy tube using a sterile arbitrator is going to go in the wrong direction, force track. Don't do that. Cover the neck with that's the stomach and ventilate the patient through the mouth. Non-rebreather is not going to help. So you don't have to memorize questions, but know them so that when they trick them, you'll be able to figure it out. Which client should the nurse assess first? We have four patients. They are all Guillain-Barré syndrome patients. So you have a bunch of GBS patients, four of them. Who is in trouble? The one who cannot lift the head off the pillow, the one who is having shallow breathing and weak cough, the one who has bilateral, severe bilateral lower extremities weakness, the one with absent deep tendon reflex in the lower limbs. For GBS patient, who do you think is your priority? Who do you need to see? Put down your answer and let's think about it. Inability to lift the head up, shallow breathing, and a weak cough, severe bilateral lower extremities weakness, absent deep tender reflex. They are all Guillain-Barré syndrome. What do you think? What is the prioritization for GPS? I always tell you most neurological questions, neurological condition that you know, all of them think about airway. If they have cough problem, if they can't swallow, if they have speech problem, that's your answer. Lifting, you cannot lift your head up. It means you're so weak. Is the early sign of yeah, respiratory problem. But because the patient has no cough and he can have shallow breathing, this is your problem. Severe bilateral lower extremities is suspected, and your reflexes is going to go down. So this question is testing your knowledge on neurology at the same time respiratory. Same thing. For patient, they have pleural effusion. Who should you see? You know the content associated with pleural effusion. The lung is bathing in fluid. Therefore, if I tap the lung, it's going to have dullness on percussion. If I listen, they're going to be decreased breath sound. Patient will have what? Mild shortness of breath. They are all buzzwords, but don't pick them because in respiratory, in proeffusion, these are all normal. Two, respiratory is 24, is going up. Saturation is now being affected, 88. Therefore, patient is suffering from the effusion and he has decreased breath sound, right? So that one is serious. C, sharp periodic chest pain because there's fluid there, right? Respiratory rate of 22 and oxygen saturation is normal. It's not suffering from it. Autopnea, when you lay flat, you have shortness of breath. It's because there's fluid in your lung. Don't lay flat. You're going to have some mild cough because the fluid will irritate your diaphragm. Patient has no chest pain. You see the way I approach it. For patients, all of them have pleural effusion. What is the buzzwords? I put it over there. But one of the buzzwords is dangerous. It's because the saturation is being affected. That's the hard one. I give you explanation. This is part of Adapt and Cleanse on demand. If you need, I have like a course on demand course that if you want to use it, it's well organized. It's not like the YouTube where everything is well organized. You can take a few weeks and go through the videos and take your NCLEX. But these are the questions, the Q bank associated with it. So the explanation is over there. It's at www.adaptandcleansereview.com. And this is caring for four clients with rib fractures. This is the same thing. They have rib fractures, right? Who do you think is in trouble? All of them. Patient has pain with inspiration. Well, if you take a deep breath and then you have rib fracture, you're going to have pain. You're going to have decreased breath sound on that side because you not take deep breath. Respiratory rate of 14. It's still not great, right? Yeah, shallow respiratory. That means his respiratory rate is basically either breathing fast or basically he's not getting any oxygen in, and still tachycardic, and it's painful inspiration. That means this may have pneumothorax in addition. Moderate pain, mild shortness, and clearing. If you're coughing and you have refractures, it's good sign. That means your lung is functioning. You have bruises on your chest, you pain on deep breathing, and you cough. Still, your airway is you clearing your airway. If you can cough, you clearing your airway. Therefore, test taking strategy. C and D are coughing, they out. B does not want to take any breath because it's painful. Therefore, that is the right answer. This is adapting because short 12 questions, high yield facts to text to your knowledge on the respiratory prioritization. I hope these two videos help you, and watch them and share them. So when you see respiratory physiology questions, you don't run away from me. Everything looks the same, but the best one is the one when you pick, you being sharp. Take care of yourself.